welcome our first speaker, Kent Dix, who is the CEO of MedApps. His talk is on the shifting dynamics between patient and healthcare providers and the future of medical devices. Welcome, Kent.
Thank you. Good morning. My name is Kent Dix, and I am CEO of MedApps, which just recently got acquired by Alere about 5 months ago, and we are now known as Alere Connect. Our purpose in life is to connect the healthcare of things at Alere and throughout the world, if you can imagine. My slide presentation today is going to be somewhat from our lessons learned, my lessons learned over the last 5 or 6 years of connecting devices, in the marketplace. Whoops, it's not about technology. Connecting devices in the marketplace, and the troubles that we've seen, the stumbling blocks that are there, the barriers to entry that are part of it as well, but also the opportunity as well. We're going to do things a little bit out of order. One of the things I'm going to show you is, maybe I'll do this in a little bit, but I was going to show you a video on how our devices are being used in the field. I can flip over to it and show it here pretty quickly. But I don't want to get into a lot of the demographics that you already know about here in the U.S. at least, and it's a worldwide problem as well, that we're getting older. Now healthcare is 1.5 times that of GDP. That's our costs are raising at 1 time that of GDP. That we have to be able to do more with less that's out there. We have people that are getting older, that are getting sicker, and healthcare costs are throughout the roof. We need to be able to, as a community, as a country, as a world, think outside the box on how we bring care to those people in a very simple, transparent, invisible, and yet cost-effective way at the same time of going through an increasing quality of care. I want to show you just a short video that was put together by Freescale about a year ago at one of their worldwide conferences that kind of outlines where healthcare is going.
20 years or 10 years, everyone's be going, oh, you mean you slept in a bed? It didn't monitor your health and tell you how fit you are, or whether you're sleeping too much or too little, or whether you're taking your medicine? All these things are going to change as we get smarter and smarter about putting the data into the cloud and being able to analyze it in real time. People will be able to diagnose themselves.
In 10 years, the ability to provide mobile health and safety services will be pervasive.
We're taking technology, and we've proven technology out there to monitor a patient, to connect them with a simple scale that connects to the cellular network, to monitor a patient to see if they've gained weight overnight. If they have, a nurse will intervene instead of them having to go to the emergency room. We've found this to be extremely effective.
Simultaneous voice communication with the ability to know what's happening around you. Have you been sitting, walking, running? What was your heart rate when you suddenly fell down?
And we have to build devices which are based on consumer electronics to make the cost of the devices really low.
When you get into the wireless domain, your communication is not as reliable as it is in the wired system. We'll need to solve the problem of risk mitigation. What happens if communication is not there? Do you have alternate methods? Do you use some other means of communicating the alarm or receiving data?
Today it is wireless, but as in the future, there will be more and more wireless alternatives to get data to your analytic tool.
I get extremely excited about new technology and about making something new function in an environment where it hadn't been possible before, such as diagnostics. Your cell phone in 20 years is going to be able to do advanced sensing, advanced imaging.
My father's 95 years old. He may live to 100, he may live to 105, but it's not just about longevity. What excites me is our ability to work together within this community of medical technology to really focus on quality of life.
Well, that was good timing. So what that video should show you is that there's a lot of things we're going to be able to do here in the future. The question isn't if it's going to happen, it's when it's going to happen. We've been fighting this battle for the last 5, 6, 10 years of trying to get technology out in the place for people to use. We're all smart engineers, right, to be able to make things talk to one another, and we always think that we have that perfect gadget to be able to make it happen. But it really comes down to one of the impediments is healthcare. Healthcare doesn't move fast. Healthcare is analytic. Healthcare, needs to have proven test cases that are out there to make sure it works. And once they have the proven test cases, they wait for others to have proven test cases, as well. But you will see this come. It is coming. It will be in your lifetime. It will be in the next, 4, 5, 10 years. If other people want it, they want it quicker than that. Our path, is, and we're in a much better path now, is to be able to do this worldwide. There's demand worldwide for this, but trying to figure out who's going to pay for it, right? Who's going to use it? Is it usable by a certain demographic of people that are out there? Is the real key challenge to all of this. So as we go through, in the US alone, we know that there's probably about 133 million people that have one or more chronic diseases. We believe that we can probably get to about 60 million of those that would benefit from this type of technology that's out there. That if you look at chronic diseases, and that's really what this is about more, we were talking about this last night, really more about than just, acute care and hospital care. This is more about chronic disease, all right, and the ongoing exacerbation that goes from chronic disease and the efficacies of technology that go to try to take care of that. Diabetes, congestive heart failure, hypertension are probably the leaders, in putting people back in the hospital and raising up the healthcare costs that are out there. But if you look at the forecast, Parks and Associates, and some of the worldwide applications that are out there are showing that remote patient monitoring devices in the U.S. basically was about 100,000 units over the last, couple years to starting 10 years ago, to now going clear above, 1.3, 1.4 million, devices that are out there within the next 8 years. It's a significant hockey stick of growth that's coming from that. But I'm afraid it's going to be a hockey stick. It's not going to be as leveled out as that is. It's going to be something that catches on and goes from there. Similar to the wireless technology, now it's projected that the wireless by 2018 will get to $11.8 billion for wireless healthcare technology in the U.S. It's a big market for us to be able to go to. So I think the opportunity is absolutely there. The one thing that I get shot down all the time is that we talk about this is the collection of data. And people will tell me doctors don't need any more data. They're already overwhelmed. They're not being paid for data out there. They just need to get to the root symptom, cause, effect, whatever it is, to be able to treat that patient. But there is a need for data. And more data is better in some circumstances, and that's when we need to feed the analytic systems through the health information exchanges, to the EHRs, to the PHRs, to the EMRs that are out there. Those analytic systems need data to be able to not only look at you and your trends and measure you against yourself, but also need the data to be able to go through and compare you to others within the population and understand who may be the first person or the person that's on that list in a point scoring that may be heading towards the hospital, and that if we intervene, we can go through and stop that readmission into the hospital or that admission into the hospital. The other thing is typically in the systems today, and we've been saying this for years, that the payers are typically, and a lot of providers too, but the payers are typically working off of data that's 60 to 90 days old. They're working off claims data. And by that time, the data, the patient has already done what the patient's going to do. They've already entered the hospital. They've already spent what they're going to spend. You may catch them on a readmittance. But what about having data that's near real time, that's transparent, that's cost effective, to allow you to give an insight of that patient to try to catch them before they even go to the hospital? And then the other thing we want to try to do is we want to try to be, in that same vein, proactive versus reactive. We don't want to just look at claims data and say, okay, Ken's been in the hospital 3 times over the last year, let's do a different regimen with him, let's educate him, let's put him under nurse care from a call center, let's give him different medications to try to keep him in the hospital. Let's be proactive with this. Let's go through and let's try to use the data that we have to try to make it in a meaningful purpose, to give it to the healthcare providers, to be able to try to educate, work with that patient, and keep them out of the hospital. There's programs out there today that are starting to ding providers, which is the 30-day rehospitalization that we're trying to help with. I don't know if most of you know, but under CMS new rules, that hospitals or providers that are on 30-day readmission, if that patient comes back with congestive heart failure, MI, and pneumonia within a 30-day period, they're at the first stage going to get reduced reimbursement for them coming back, but ultimately they're going to get no reimbursement. That's where it's kind of heading to for that patient coming back. That now means the provider's got to get it right. The provider has got to try to get with that patient, try to use technology to try to go through and connect with that patient to try to keep them out of the hospital, to be able to reduce cost. The other thing is that we've looked at with this as well, we want to keep the systems that were developed, like I said, very transparent. We want to keep them very simple. We want to keep them very cost effective. We want to be able to, as I say, we don't want to give them the CIA effect. We don't want to take the nurses and the doctors out of the equation here and to just have a massive amount of data that can't be interpreted, by people. We've got to be able to give data in a very meaningful format back to the caregivers so they can act upon it for the future going forward. I used to have the slide before this which showed the evolution of the internet when Al Gore created the internet, that we could go through and show where the hockey stick started to occur. And what I believe is that we are approaching the perfect storm for this type of technology. You're starting to see standards being set, HL7 that's being set out there, associations like Continua that are setting interoperability standards between devices. You're starting to get regulation, which is part of the perfect storm in there, with the CMS rulings that are coming. You're starting to see the government working with Meaningful Use 1, 2, and 3 to try to incent these type of devices and systems and connectivities to try to occur. So all of that is coming in this time frame right now with the advent of new type of wireless technology, and the cost is starting to sink with that as well. So you're starting to see that perfect storm starting to occur. Basically, if you start looking at the devices that I'm talking about, that I'll show you in just a second, you're starting to talk about a very commoditization, of these devices that would go with patient. The lowest cost you can try to imagine. Where we're seeing cellular cost in connecting patients 3 years ago in the $8 range, in the $5 range. Last year they went down to the $1.50 range, and this year they're going down into the 50-cent to 20-cent range for being able to send data through carriers worldwide, roaming, 142 countries, right, to be able to do that. That's unheard of. So when you have that kind of technology and you have that kind of pricing, it's a game changer. It allows you to now start looking at how you take that technology and bundle it with services to be able to provide value to the healthcare organizations. The one aspect that we typically come from, or I typically do in my division, is actually being very pragmatic about this and looking at this from a very different perspective and being very real. There are a lot of people that stand on stage with smartphones and ECG and say, hey, this looks great, and be able to have a diabetic meter and this looks great, but they haven't told me who the ultimate market is and who the ultimate person who's going to buy that. It looks sexy, it looks cool, right? But who's going to buy that on a regular basis? I hear them explaining that this is what it costs to get a patient in the hospital. I hear this is what it costs to keep them out of the hospital. Won't they go through and pay this for my device? And we're not seeing that in droves right now. What we are concentrating on are the actual people that are spending the money, the 20% that are consuming 80% of the healthcare cost. And the demographic is made up of basically selling to B2B organizations out there to package it in their solutions, but made up of seniors and made up of indigent population that have chronic disease. These are the people that we target to go after. The other 20% that are out there that consume, the other 80% that consume 20% of the healthcare, which I consider more proactive wellness organizations, we at Lear do address that, but my division doesn't. I'm talking about the experiences today from the 20% and the 80% rule. So there are a lot of cliches that go around about this, and I want to kind of explain about the cliches. Some of them are funny, some of them are not, but the one thing you necessarily need to take away from this is that if you build it, they won't necessarily come. Right? So there's a lot of entrepreneurs out there that startups saying, I know how to interface this device to this cell phone or to this wireless network, and this is how it's going to work. Not necessarily true. It'll work, but are you going to be able to sell it? One of the big questions you have to ask is who's going to buy it? What are they going to pay for it? What gap are you filling, out there that others are not in this? And can you protect your invention too? So you've got to make sure that it's sellable, protectable. And I truly do believe that it does take a village to raise a healthcare system. That it's not about just that one thing that's going to be created to be able to keep everybody out of the hospital. It is a combination of things together, bundled with services and solutions to be able to make it happen. I say this a lot, that the technology, and I'll call myself a geek. I have an engineering background, but we like to create gadgets, we like to create widgets. But with this is really about 20% technology and about 80% psychology. When we're dealing with patients that are in the field, right, it's about, a lot of times, it's not about what the gizmo and the gadget does. A lot of times it's about that the gizmo or gadget is in the house. They may not even know that, but they know they have accountability to somebody. They know that their daughter is on the other end. If they miss a reading, that the daughter's going to give them a call. In my case, it's my wife, and then the voices start in my head, with that I missed a reading. Or it could be a nurse call center where the data was missed and the data needs to come in. So it's that psychological, that invisible kind of leash that's there that actually allows them to do it. And it's also about the total cost of ownership. One of the things that we're really fighting in the industry is, what does it cost to deploy that unit? And that means, does a nurse have to take care of it? Does a doctor have to take care of it? Does a caregiver have to take care of it? What is the least total cost of ownership? Not just ROI, but least total cost of ownership. When we first started installing these devices, we were replacing systems that had very high cost, but it made the vendor delivered them to the nurse's doorstep. The nurse then had to install them, and if they had to repair a device, get rid of a scale, a blood pressure device, they had to go out and rechange it. They had to replug it in. If they had to update firmware, the nurses had to update the firmware. It's not where the healthcare wants to be, and that's where it comes to the next one is they want to be clinicians, not technicians, right, with us. So that's where we have to think outside the box and how we connect to devices. We do it through the cloud. We do it through firmware over the air. We do it through automated delivery and distribution systems that are out there to be able to get to that patient and to be able to connect to them. And then a big one is one solution doesn't fit all. You're not going to, again, create a solution that you think, I'm knocking it out of the park. You may for a segment, but it's not going to be the end-all, be-all solution. It takes a lot of different solutions to try to get patients compliant. And this is what I mean by this. It's not a great dramatization, but the first line kind of represents, the means of connectivity. A lot of people come to me and say, why do you create your own device when you have tablets or you have smartphones? Why don't you just use the computer the patient has or the smartphone the patient has? Remember the 20% that consume 80%. Does a senior population, does an indigent population have those tools or can use those tools to be able to do that? Or is it better to put something transparent in the background to try to collect it? In the case of us working with Medicaid patients, when we first gave them a smartphone, we first gave them a tablet because we're smart guys, we can write applications to do this. We found that our smartphones and our tablets ended up in the pawn shop. We found that they're used for downloading music instead of taking their biometric readings by their sons or daughters that are out there. So we had to create what's called a non-hockable device. Has no value except for just connected and sending data where it needs to go, and the patient doesn't even really know about it. So it's easy to go through and say, why don't I just use a jump drive? In some circumstances, it may be the case. If we're serving a population that has computers and they can talk wirelessly to a jump drive and the data's there, why not do that? Or voice over IP, or laptops, or smartphones, or tablets, or standalone systems that have M2M cellular built into them that the patient really doesn't know much about it. Or kiosks that are that, or any combination. Or we have to look at sensors in the middle row that could be as simple as a Saturday through Sunday pillbox. It has no technology to it, but it might be the thing that 20% technology, 80% psychology, that actually gets the patients engaged and going. It's not always about technology. It sometimes is a lot about process in there as well. So it could be an automated pillbox. It could be, sensors like scales and blood pressure and pulse oximeters, or, the iRhythm, devices transmitting data, back and forth, or clinical devices or implantable devices. What are we trying to communicate to? And what frequencies are we trying to communicate to? Are we communicating on Bluetooth, Wi-Fi, mixed frequency for implantable devices? And then the bigger one is the demographics below. We need to talk to multiple different demographics. Who am I talking to? The teenager that has no incentive that's got a smartphone, that has no incentive to monitor their health, the baby that can't make that decision, the indigent population that doesn't have the means to do that. I mean, I see statistics that come out to talk about that there are 59 to 64% of people nowadays with chronic diseases that have smartphones. The problem is when you start getting down to the populations where it's that 20% that consume 80%, a lot of them are using prepaid smartphones. You can't load programs on them, right, from that standpoint, and they throw them away every couple months, so trying to keep track of them is a big problem with that as well. People have tried to come out with healthcare prepaid smartphones, aligning with Walmart, right, to be able to do that. That might work. We don't know yet, but we're trying any means possible, any combination possible to be able to do that. You have fitness people, obese people, rich people, poor people, and then our senior elderly people as well. So it is taking any one of these alignments and trying to figure out what works for this group. What we try to do with this is very simply, if you kind of look to the left center, there are multiple devices that are there, and this is where I kind of come from the Lear perspective in learning about this. We've got 3 devices that we kind of put out with the population, given all the parameters I just talked about, is that we have what's called our mobile link, which is just a single biscotti-sized device that has cellular technology inside of it that connects to a point-of-care device. It could be a scale, blood pressure, INR, CD4, analyzers, whatever it needs to be connected to, and sends the data to the cloud care system, to the cloud to be processed from that. We have the MyLink system, which is a mobile, it's the one that's standing up in the cradle, a mobile system. But when I talk about mobility, I'm not necessarily talking about you're carrying it around with you all the time. I'm really talking about portability, meaning that when you want to go to your son-in-laws the patient wants to go to son-in-laws for a month or two, and they're tied to a computer that has everything plugged into it, they're not going to unplug everything and take it to their son-in-laws. They're going to stop monitoring themselves and go on vacation. And that's where the problems occur because the monitoring is stopped. We want to be able to have them take these devices wherever they're going and connect to the cellular network. We have this being used with truck drivers right now on a regular basis. The truck driver takes readings in 48 states right now. He used to have to go back, the couple of truck drivers used to have to go back to get medication changes with their doctor at Cleveland Clinic. And it doesn't work that way anymore. What he does, he sends his data in. He has a phone conference call with his doctor. The doctor reviews his personal health record on MyChart. The doctor will make prescription changes if he needs them, and then he'll go through and send the prescription over to a pharmacy. Cleveland Clinic's a little unique with that program because under normal circumstances, doctors don't get reimbursed that way. And that's where we have to start working on more of the regulation side to make sure that doctors and physicians and caregivers can get reimbursed for the care they give remotely. And that's one of the biggest changes that has to come about. But we send the data through the hub, either wired or wirelessly, into our servers, into our back-end system, and then send it into the cloud after that, which is the big thing that's coming from Meaningful Use 2 and Meaningful Use 1, is integration into Health Information Exchange, which then integrate into EMRs, EHRs, PHRs that are out there. We want to be the last connectivity of pipe that's to the patient. We want to be able to be that medical hotspot that is in a patient's home that they may not even realize is there, right? That's taking readings from their devices and go clear through the HIE to the EMRs, into the analytic systems, and be able to ask additional questions to the patient that may be useful. Like, I see that you're hypertensive today. Did you sleep okay last night? Did you take your medication last night? Did you exercise yesterday? How many pillows did you sleep with last night for your pain level, right? All that may be needed to be able to go through a decision support system and decide if additional care is needed and be escalated into a nurse call center. A lot of this is going to be about exception processing. It's going to be about looking at what's normal for the patient, what's normal for the industry, what data is coming in, what's going through the decision support systems, and deciding who needs care immediately or who needs education, right, as well. The markets that we've identified and we've talked to a lot of people about, that we think are ready for this type of technology are 5 distinct markets. One is obviously rehospitalization, one that I talked about from congestive heart failure. The other one is accountable care organizations, right? There's a large push now towards ACOs and moving away for fee-for-service and payment to be able to now do pay-per-performance, accountable care, to be able to say, tag, you're it, you own this patient, here's $2,000 a month for taking care of the congestive heart failure patient. If they go in the hospital, 3 times during the year, it costs you $10,000 a piece at $30,000, you basically lost $6,000. If they go in two times a year or 1 time a year, you're making a profit on this. But you also have to give quality of care as well with it. So the advantage with technology like we're using now is stay connected to the patient under an ACO strategy to be able to try to see trends and try to intervene before they head to the hospital. Home health care agencies, which are contractually obligated to CMS payers that are out there, to be able to take care of patients, are using this to be able to deploy nurses in a more effective way, but also deploy nurses where they need to go to be able to attack the problem in a more effective way as well. If they see somebody who is showing signs of going into the hospital or exacerbating their disease, then they need to be able to probably send a healthcare provider out there more frequently to be able to do that. Maybe a yellow reading will say that they need to educate the patient more to try to stay out of those zones. Clinical trials, pharmaceutical is another big thing that's looking for data from patients remotely on a regular basis. And so, sorry, this got copied over, but the last one is OEM devices. We're finding a lot of devices out there that are needing this type of technology. One of the things I've got a personal mission for is anything that has created a hard center where we have to take a patient into to receive care, like dialysis, right? Or like pain management centers, or like coagulation monitoring centers or diabetic centers. I want to be able to connect to those devices and actually have the patient do the work from home instead of actually sending them to the center. I mean, imagine on dialysis centers. I know not everybody can do peritoneal dialysis, but imagine that we were dragging the sickest of the sick to centers 3 times a week for 5 to 6 hours at a time. Instead, we could actually potentially be doing that at home and allowing nurses to be in that center to be able to monitor the patients while the patients remain at home connected to their caregivers instead. If you think about the hospital room of the future, a lot of things that we do in the hospital around the bed now are actually going to be done at home. When you push that button for the nurse, you're going to be pushing it from your home bed with probably your family caregiver that's there with you. That goes to a nurse call center. It doesn't go to the station down the hall, but maybe you don't know the difference from that as well. You connected video-wise with that nurse caregiver as well. Your biometric readings that you're producing out of your home from devices that you have in their home will go into a central EHR, PHR, EMR that a doctor can see that's at the hospital instead. So there's been a lot of work with us on key people that design around the hospital room to try to deliver this type of technology connected, but at home instead. And from our perspective, from Alir's perspective, I just want to bring this in just a little bit. We obviously very patient-centric, but we build the patient around the patient certain, we call it the onion, certain areas that envelop where we need to concentrate on. The HIE being the first one, the Health Information Exchange being the first one, that then talks to the EHR, PHR, and then the devices around it. And then we talked about data that comes from the HIE or for the EMR, PHR, that can go into analytic systems and other tools that are out there to be able to do encompassing the whole gambit of ACOs. Now, if you imagine the data flow I just talked about coming from the device, coming from the patient through the HIE or the device into the analytic system and back with that, we want to be able to pass data in to it to be able to respond to that patient within milliseconds if we need to, if we can intervene. And again, it's not just about, I'm supposed to be talking about the changing dynamics here, but it's not just about the device itself. It's about the services that you bundle around, everything that we have to take into account to be able to make a total system for ACOs and for others out there to make this a useful system. It's just not that gadget to make. The gadget is just part of the equation. When I kind of look at the ecosystem of the patient-centered care, I add additional things to it as well. One of the things, I know that there's devices out there, but I know people are coming up with smartphone applications for gaming. God, if we could make an Angry Birds application that would bring down hypertension, that would be great, but I don't think that will be possible. It's counterintuitive with it. It makes my blood pressure go up. I think that we need to build loyalty programs, reward programs, around patient care as well, especially when you're out on the fringes with the care. Voice, there can be lighter solutions, interactive voice response units. Although, from an IVR perspective, I've found that patients can tend to manipulate those. They can go through and say, I don't want the nurse call center to call me today. My INR reading today is 3, when it really should be 6, right, instead. On the other side of it, you find people that go through and say, I really am lonely today. I want the nurse to call me, so I'm going to put a 6 in, when it really is 3. So what we're trying to do is try to be very, very much connected to the patient, to their actual device, so the patient can't intervene and put wrong readings in. Their logbooks are in themselves as well. And so there's a whole different things. I mean, even we've talked about social networking. Wouldn't it be great? All my HIPAA experts don't get me on this. I understand the sensitivity, but wouldn't it be great to be able to show to family members and show to the community that you choose how well you're doing, right, in that community, be able to take all that data that's collected and to be able to coach you along the way or give you advice along the way as well. So again, this is what I mean about it takes a village, education's part of it as well. This takes a village to raise the healthcare system. And there was one other video I wanted to show you real quick. This is our slide or our video at Meridian Healthcare in New Jersey that we did on CNN. It was done on CNN.
If you're looking for which direction the early winds of change are blowing with healthcare reform, you'll have to come here to the Jersey Shore. I'm here at Ocean Medical Center. This hospital is engaging in a fascinating new trial in remote healthcare monitoring that's using some basic technologies to fundamentally change the relationship between healthcare providers and patients. Now, the key driver here are certain features of the healthcare legislation that are forcing local hospitals to be as efficient as they can be in providing healthcare. And they're trying a pilot program that is taking patients' weight and sending it back to the hospital for analysis. And how they do it is a fascinating example of simple technologies applied for a complex problem. They use an off-the-shelf wireless scale, but you can't send unsecured information like this because the regulations don't allow it. So they use a secure system from a company called MedApps to wirelessly send his weight back to the hospital, and suddenly the dynamic of patient care changes.
Well, basically, every day I get the patient's weight on a daily basis, and I can tell at a glance the patient's trends 24 hours ago, 48 hours ago, a week ago. So I can kind of gauge to see how they are as far as retaining fluid, because that's a classic symptom as far as detecting congestive heart failure. And we can see the trend is that the weight's slowly going up. The patient's definitely having some issues. The whole idea of this is to catch the fluid retention before the patient develops any symptoms, which will bring them to the ER.
I had a congestive heart failure. They took me to the hospital, treated me there, and then they contacted me at the hospital if I would be interested in doing this pilot program. I said, sure. I thought it was great because if I gained 2 pounds or more, they would call me up and let me know that I had gained 2 pounds. It kept me constantly watching my diet, what I ate.
Where a nurse going in the home can maybe see 6 or 7 patients at the most in one day, I can review 20 in an hour.
There are powerful new technologies that are coming into practical use that were once inconceivable just last year. I'm Jonathan Bloom in Central New Jersey for CNN Money.
So that's one of the, we'll get to the pilot here in just a little while, but that's where I'm going to kind of intervene and say that it was 20% technology, about 80% psychology. The pilot that we did at Meridian, although small, wrong word, actually when you experience congestive heart failure, usually 27% of patients come back in the hospital in a 30-day period. That's the national average. I think Meridian's like about 24%. What we found out on this, and then 47% come back after a 6-month period. With this pilot and doing about 30 to 40 patients, we found that 0 came back. And that is not a norm with this by any means statistically. But we believe it's because of that leash, that 80% psychology. We believe it's because the nurse is on the other end that actually caused the interaction to be able to stop them. If they're gonna not go out and eat pizza, right, the night before that's full of salt, and then blow it up and then go to the emergency room 2 days from now, right, because they're retaining water. They're going to be much more on it. The family caregivers are going to be much more on it. The one thing I really haven't explained that I'm a big advocate of is the 60 million family caregivers that are out there. Every time I mention mom and dads, right, that they have to take care of, that are out there, we're all about that age, to do that, it perks up because we need tools to be able to help us, right? I am looking for somebody to develop, you know, a UI front end for my Mac that I can sit there and to be able to see from a Facebook kind of way what mom's doing, you know, and can I help her and say, mom needs to go get her hair done or needs to go to the doctor on Thursday, sis, are you going to be able to do that, right, instead, and help with the caregiver of our family. Mom didn't take her reading today, you didn't take your medication today, why didn't you take your medication today, right? We can't leave people siloed and on their own. I think the family has to get in there to be able to help, and we need the tools to be able to do that. As far as existing technology, this is not, remote patient monitoring is not brand new. It's been out there for years and years. We used to have Jay Saunders on our advisory board, who's the father of telemedicine, working with companies that are out there to provide typically boxes that plug into phone lines that are DSL and others that are out there that cost you know, sometimes between $4,000 and $6,000 to monitor a patient. Because of their costs, they're being used in a very reactive mode. They'll put them with somebody that's been in the hospital, get them stabilized, and then take them off the device and give it to another patient. What we as an industry are now pushing to is devices that are consumer-oriented, using consumer devices out there, scales and blood pressure and pulse oximeters and other things that are on the consumer shelf, to be able to go through and connect to them wirelessly, drive down that cost, but leave it with the patient cost effectively so we can be more proactive in working with the patient instead. We're still at Cleveland Clinic working with them. They're using us, we're using them as a sandbox, they're using us as a guinea pig to try to figure out how things work. And this program in particular is where I've got my truck drivers as well, but it deals with the population, just a couple hundred patients, but we've had them for the last couple of years. And looking at the dynamics of how things work, these patients themselves are doing patient self-testing, which isn't the best, right, that's out there for results that are concerned. It's better than nothing, but there needs to be something behind this, and this is what we're learning, that you know, that we need to be able to have the data pass into either analytic systems, or we need to be able to have it go into nurse call centers so somebody can watch it. The programs that we're in pilots with that have nurses or somebody on the other end are a lot more effective. The compliance is in the 90% range, where this compliance sometimes goes down to 40 to 50% range. So PST, you know, there's this whole aspect of what makes a patient, you know, want to test and to keep testing, you know, that's out there that we have to really take into account. Although, you know, on some of this, we actually, on the diabetic patients, we actually increased the number of days by 71% that they went to see their doctor, which is good. On our congestive heart failure patients, 27% time frame, they went to the doctor more. And they're saying, well, wait a minute, is that a problem? No, because they went to their doctor instead of going to the emergency room with that. That's viewed very positively from at least Cleveland Clinic's perspective. On Meridian, we talked about that as well, that we had 100% coming out. It was on the first 30 days of discharge from the patients that were out there. And very successful from that, but that was a pilot. And we're in the stage of going through and trying to roll out more of these pilots that are out there. And then just some other key ones that we've been working with as well along the way. The interesting one at Wharton and the University of Pennsylvania was they were using our system, and they're still using it a little bit right now, but they're using our system as more like a lottery terminal. The more that a patient took their reading, the more that they were entered into a lottery to receive a cash bonus, a cash incentive to do that. And when I was in Washington, we were talking about this, people would kind of snicker at that. You mean we're paying people to take their readings? We're already doing that. I mean, organizations, disease management organizations already do that today they do anything to try to get a patient compliant. It's cheaper to do that, to give them a $20, $30 Walmart card for being compliant than it is to go to the emergency room and to stay connected to them. So yeah, we are doing that today. Partners Healthcare is being very successful in using it in rollouts right now as well. Indian Health Services, we're at 12 reservations right now, and we're using them in very remote locations. The only one we're going to have trouble with right now with cellular is the Aleutian Islands. But we're in Arizona, we're in Idaho, we're in Oklahoma, we're throughout the United States on the Indian reservations, and we're getting good results as well. And then Crondelet is working more for the pilots with more of the nurse caregivers that are working with the Spanish-speaking population that's coming in along the Arizona-Mexico border to try to work with patients to try to get them stabilized and help them before they have to enter the emergency room on a regular basis. So those are just some of our key aspects. In conclusion, what I'd like to say is the time to act right is now. We need to deliver systems that are innovative and they engage patients. We need to work together in an ecosystem. If you're thinking about developing, reach out to people that are already in the space, that have gaps of things that they're not doing to try to fill those gaps in there. Invest in new technologies, learn from our mistakes. We have to do that. That's what Al Gore did when he invented the internet, and venture capital came in. And then continue to provide the best quality of care to patients, improve efficiency while lowering cost. We constantly have to strive for that. Thank you very much.